Good evening, everybody. Today is 9/2/2020, and this is another episode of In Your Corner with CORA. A very, very interesting topic tonight. We're talking about pectoralis major injuries, which in a sports practice like ours, mine and Dr. Brown's, it's something we see not infrequently and has implications, which we'll talk about. So before we get started, I'm Dr. Lehman from the 314 St. Louis, Missouri. Dr. Brown, could you please introduce yourself?
I'm Dr. Andy Brown. I'm from St. Louis, Missouri as well.
And I'm Nate Gibson. I'm the physical therapist in University of Tennessee.
You're on, buddy. All right, so we're going to get started here. Dr. Brown, starting out, let's just kind of set some parameters and tell us about the anatomy of the pec major, the pec minor, and the function. What does the pectoralis do? Why do we need the pectoralis?
Well, the pectoralis, as most weightlifters know and most athletes know, provides strength in pushing the arm forward and across the body. For football linemen, it's critical. For combative athletes, you have to strike blows, and it's important for swimmers as well. Anyone who has to push, thrust, and use their arm with any measure of strength in front of the body, it's a critical muscle. It's a group of muscles, the pectoralis major and minor. The major is really the one that gets torn the most. And it has two basic muscle bellies. One comes off your ribs, and we call that the sternal portion. Another part comes down off of the clavicle, and they sort of twist and blend on the arm to give different strength in different positions and different leverage. But it's a critical muscle for athletes and that have to do any kind of pushing or thrusting with the arm.
And why don't you tell us where the conjoined tendon and the tendon of the pec major and minor inserts on the humerus?
Well, they kind of come in the front. You can see them if you look in the mirror. They come in the front of the muscles of the rotator cuff, as well as your biceps tendon that goes up into the shoulder joint as well. And it kind of tucks just in front of your deltoid muscle as well, kind of just before you get to the deltoid. So it's right in the front. It's in the thin person, it's actually quite easy to appreciate, especially if they push their hands together in a prayer-like position. You'll see a thick cord of tendon there, and that's where the muscle inserts onto the humerus bone.
That's great, and that's right, and it inserts, actually, it crosses over the biceps tendon and inserts into the humerus. And you're right, and most people who have developed pectoralis, you can feel it, and when it's torn, you can feel that it's not there. And if you look at their involved versus their uninvolved side, there's usually a pretty significant difference, and maybe some hematoma, some bleeding, some discoloration. Dr. Brown, give us, you kind of alluded to it a little bit, but give us the most common and the mechanism of injuring the pectoralis. Patient comes in, what's he tell you when he's torn his pectoralis?
Well, usually it's going to be a bench press. That's in most studies and series, it's shown 50 to 55% are going to be people bench pressing, pushing a large load, and then they feel a pop and lose control of the weight with instant pain. The very first described case in the literature was a meat worker lifting a giant side of beef and felt a pop. We don't obviously hear that quite as much anymore, but it is a common weightlifting injury, occasionally with linemen, especially offensive linemen, pushing defenders away. They can pop it that way, but the vast majority is going to be a weightlifting injury.
That's right, thank you. So Nate, patient comes in, says, hey, I felt this pop. I went to the doctor. They told me I had a pectoralis major tear. They're thinking about surgery versus non-surgery. What are you going to do for that patient prehab, before surgery, before non-surgery? How are you going to treat that patient initially?
I think a lot of times what we look at is we definitely want to check and see the extent of the tear, what happened with the doctor. We also look to check and make sure what goes on, what the doctor wants from an initial protocol, if the surgery is going to be recommended or not. We do test out with the prayer stretch to make sure that that kind of goes in there. We initially check out manual muscle testing, and as well as range of motion. With that initial acute injury, we definitely want to make sure that we're controlling their pain, their inflammatory response, and any type of bruising that we have. So the biggest thing we definitely want to do is make sure that we restore motion, reduced pain, and then maintain some type of scapular stability involving things around the shoulder blade. So that way we don't have any type of muscular atrophy within the shoulder and lose function.
No, I think that's good. I think it's important to regain range of motion before you embark on fixing the pec, however you're going to fix it, because if we're stiff going in, that makes the rehab on the other side pretty tough. Dr. Brown, so patient comes in, says, I was trying to PR on the bench. I felt this pop. I've got this bruising, positive prayer test. You can't feel the pec. There's some drooping of the breast. What do you tell that patient? Surgery, non-surgery? How do you treat that patient? What do you do?
Well, it's individualized, of course, but you know, most people in this day and age want to stay active. They want to lift weights. They want, if they're a competitive athlete, then, you know, certainly to maintain that strength, you would probably recommend surgery. Now, is it critical to have surgery? No. I mean, not everyone has to have this fixed, but they're going to have to accept the fact that it does visually look different and can be significantly different in people with the droop of the muscle and then this kind of loss of the contour by the shoulder. You know, I've had one patient who was very concerned about the cosmesis because he was a bodybuilder and they have to do their poses and things, and his chest really did look quite different side to side. And so that was one of the reasons to fix it, in addition to preserve the strength. But any kind of lineman in football or combative person's probably going to need to have it fixed. A wrestler, a martial artist, they're going to need that strength, because the strength deficit can be pretty significant, up to 40% loss in isokinetic strength in certain studies if you don't fix them. And many studies have shown the superiority of fixing it in order to preserve the strength.
Like ours, I agree with you. More chances than not, we're going to go ahead and say, hey, let's fix your pec. It's not an older man's injury. It's a younger man's injury. It's somebody who's lifting. So if somebody comes in and they're not really worried about their strength or their function, but they're just worried about their cosmesis. One breast is drooping. It just doesn't look symmetrical. What do you tell that patient? Do you fix that patient?
Well, if they understand the risks and you know, the fact that there are some risks associated with it, but I do think at the end of the day, they will enjoy better strength, whether they're improving their cosmesis or not. But it's a relatively straightforward surgical approach. The complications in general are relatively minor, with this local irritation to the wound, maybe some stiffness, which the therapist can help you with. But most patients can get a good result, and the anatomy is rather straightforward. So I wouldn't have a problem fixing someone who wanted to make sure it didn't have a strange appearance. But again, they would have that added benefit of dramatically improved strength, and so I wouldn't tell them no.
And so here we are. We're in the operating room. What do you do? I mean, how do you fix this thing? You got this torn tendon. The guy comes in, breast is droopy. He's got some weakness in adduction, can't push off. How do you fix this? What do you have to do?
Well, there are some different types of tears. The simplest to fix is when the tendon pulls off the bone, and you can, in a number of different techniques, create a little trough in the bone to create some bleeding and sew the tendon back down to the bone. You can use simple tunnels with suture, or there's more sophisticated suture anchors, but basically you're trying to get the tendon to heal back down to the bone. And so you get it down to the bone, and usually it'll heal. The tricky ones are ones where the muscle has torn away from the tendon. So the tendon's still attached to the bone, and you got to get this muscle attached down. Or a neglected tear that is scarred down to the chest wall and is, you know, several months old. and the tendon is shriveled down. In that case, you're probably going to need to use some donor tissue. And that's why, in general, I tend to get an MRI for these to assess the location and type of tear, whether it's the muscle tearing off the tendon or the tendon off the bone. And then you can be prepared with either you can use donor tissue, or we have these wonderful dermal patches now that work well with dermal tissue that's been processed. But it can be as simple as sewing it back down to bone, or weaving the muscle back down to the tendon, or using a graft to replace the tendon. But again, those are usually the more neglected tears.
So if the tendon's retracted and you get in there and there's really not much tendon left, and I had one of these not that long ago, and we ended up weaving a hamstring through the musculotendinous junction, what kind of a result can you expect versus an acute tear?
Well, they actually do relatively well. Cosmetically, you definitely recreate the band of tissue in the front, and the healing has been shown with patches and grafts to be sufficient, such that you can expect to get at least 90% of your strength back. So they actually work relatively well. It's just a harder job for the surgeon at the time of surgery. And then a little bit harder for the therapist, because you have to hold back just a little bit and not, be as aggressive with the therapy, which always, is a more of an art for the therapist, deciding when to push things. I mean, a tendon heals down to bone predictably by 10 to 12 weeks, but these patches and things, it's a little bit longer. And so for the patient, it's a pretty similar result, but for the people working on it's a little tougher.
Dr. Brown, when do you send the patient to rehab? How long do you keep them immobilized for?
Well, that depends a little bit on the patient. If there is someone who needs to let their wound heal, maybe no more than a week, maybe 10 days. But in general, I like to get people in as soon as I can, so they can at least start working on elbow motion, wrist pumps. There's techniques that therapists can do for reducing pain and swelling. So fairly quickly. But again, it depends a little on the patient, a little bit on the quality of the repair. But most people I want to be seen within 7 to 10 days by the therapist.
Thank you. All right, Nate. So it's a week out, and Dr. Brown's patient shows up. Explain the therapy, what we need to do, what we need to accomplish, and how long do you think it's going to take to get that patient back to bench pressing?
Okay. When they first come in, we're definitely looking at preserving the healing as well as reducing pain and inflammatory response. We usually start off with some type of cold modality, even involving some type of electrical stimulation. We want to work on pendulum, as Dr. Brown said, that we want to definitely start to work on the grip, wrist, and elbow motion. That would be the initial phase. I usually kind of put that into anywhere between the first 2 to 4 weeks. Then we'll go into an intermediate phase where we're starting to kind of apply passive range of motion and flexion, external rotation, abduction, which is going to be limited due to the surgical repair, dependent on what the doctor's protocols are going to be. We're going to have shoulder isometrics, but we're staying away from internal rotation as well as flexion to preserve the integrity of the repair. That's usually around 3 to 6 weeks is what I like to do. But as I said, depending on the surgeon, we usually follow their protocol. There's a late phase, which kind of involves the 6 to 12 week period where we go from isometrics to isotonics. We're going to be working in a shortened muscle length, working into a neutral muscle length. That's going to start to involve strengthening with PNFs as well as TheraBand. We're going to work in scar mobilization, working towards full shoulder range of motion, as well as rhythmic stabilization. And then we're going to go into an advanced phase, which is anywhere between 12 and 16 plus weeks, where we're increasing everything before, working on endurance, stabilization of the shoulder, as well as working towards that bench press for you, limiting from more of a progressive overload to make sure that that tendon is actually able to absorb the load and work how it needs to.
So when the patient comes in, and the first question they always ask me is, when can I get back to the gym? When can I bench press? You tell them 16 weeks, or What's your thought process, Nate, on when they're ready to go back independently back to the gym and maybe start some low weight, high rep bench or incline press or biceps, etc.?
Okay. Usually, as I said, I do follow the doctor's protocol, and I want to definitely confer with them to get that. But from a standpoint of that, when people do say that, it also depends on the type of repair that was had and where the tear was. Like Dr. Brown said, if it's going to be torn away from the tendon, we're going to have to work a little bit longer and allow that to heal anywhere between 10 and 12 weeks. So normally from that to adhere back to the bone, like Dr. Brown said, 10 to 12 weeks, I would probably put it around in there. Now then, from starting from a strengthening and isometric standpoint, we can go ahead and start some carries and things, but I would want to protect that repair to make sure that we're able to get back with that progressive overload and then also not do too much to re-injure the repair.
Thank you. That was excellent. And I agree. Everyone's a little bit different. Some people you got to pull back a little bit because they're crazy. Like I had a guy today, and we just fixed his knee, and he said, "When can he run?" And he's non-weight bearing for 6 weeks with a meniscus repair. And then some people, they come in at 3 months, are still on crutches. So same thing in the shoulder. Some people you're going to have to push, and some people you're going to have to pull. And I think we find out who those patients are. But I do think the 3-4 month period is a reasonable time to tell the athlete, hey, you can start some light workouts in the gym. Again, low weight, high reps, and progress. And I think with a good repair, that's a pretty safe time frame. Dr. Brown, someone comes in, they tore their pec, they hate doctors, they hate surgery, hate the whole thing, and they say, look, I'm just going to live with this problem. You know, my droop is not bothering me, and I'm just not going to do anything about it. What can they expect? What kind of strength deficits can they expect, number one? And what can they expect as a result versus somebody who may have had it fixed?
Well, I think it depends on the activities they're going to try to do. If it's just a recreational athlete who plays racket sports or swims or bicycles, does some weightlifting just for cardiovascular fitness, I don't know that they'll notice too much. Now, if it's a laborer who has to lift and push, they might notice some problems at work. Yeah, we mentioned earlier the first report was a person working in a meat packing plant. I mean, if they have to do a lot of lifting, they might notice some deficits. If they are a grappler or any kind of combative sports, they might notice some problems with posting or trying to do any sort of close-in grappling maneuvers. I think that for the most part, though, people who choose that are probably self-selected. They're not really doing those sorts of things. And so, but they might notice some strength problems. They're usually not very painful when they've not been repaired. So pain isn't usually a problem. Usually they get their range of motion back, but they would just have weakness in certain moves when they're pushing the arm forward and in front and across the body. It's just going to be weaker than if you had it fixed. It's pretty clear from meticulous studies that have looked at that, but you might be able to live with it. It just depends on what you're going to be doing.
I agree. That's excellent. All right, Nate. So somebody comes in, they didn't have surgery. They complain that they're having some problems pushing off, as Dr. Brown said, adduction across their body. They can't really do a pull-up. Is there something we can do about that? Give us a program to, and again, we know we're not going to get them back to normal. We're not going to get them as well as they would be post-op. And I've seen some of these patients that refuse surgery, and they do have a significant deficit. I got a patient now in my practice who's a swimmer, and he's upset with himself. He didn't have it fixed. We're thinking about possibly reconstructing it. But what can that swimmer do to put his best foot forward to possibly avoid a reconstructive surgery, which certainly is going to be a little riskier, number one, and a little longer in terms of rehab, number two, because you're going to have to protect it. What can the athlete who says, you know what, I don't like doctors, I don't like surgery, I've had it, I'm just going to go home and live with it. Is there anything that athlete can do to best train and secondarily strengthen the structures that support the pec, hoping to minimize their strength deficit.
Exactly. Yes. If they don't want to go into the repair, we have a lot of people do that. I've actually had somebody do that beforehand. You know, a lot of the things that we look at, from the multiple angles of the shoulder being one of the most movable joints, as well as having a lot of other muscular attachments. Even though the pec is a large muscle, you still have a lot coming in that anterior portion for your flexion, horizontal adduction, extension. So one of the best things to do would be to work around everything involving the scapulohumeral rhythm, to where we want to focus on bicep, tricep, deltoids, working to check and make sure that your scapulothoracic area is going to be mobile as well. So a lot of it is going to be able to, if that repair is not going to happen and that muscle is weak, we definitely want to make sure that the supporting cast of muscles that are there are going to be strong to take over for what is torn. So that way we prevent further shoulder damage, any type of impingement or rotator cuff injury as well, due to still having that pec tear. So it's a full shoulder strengthening surrounding everything there to make it better and prevent shoulder injury.
That's excellent. So you guys, listen, this was excellent. I think a lot of information. Again, it's a injury that isn't very, very frequent, not like a rotator cuff, but we see them on a routine basis. And we tend to repair most of them. And most patients want them repaired. We have a few people that decide not to have them repaired, and we do just what you talked about. We try to rehab all the secondary stabilizers, trying to make the shoulder as strong as it can be absent the pec. I have had a couple of patients, as Dr. Brown talked about, that were bodybuilders and were contestants, and it's imperative for them, just for the cosmesis. Obviously, they are happy they got stronger, but when that one breast droops, it looks very weird if you have developed pecs. If you look like me, you probably couldn't tell. It's not going to really matter. So I think informationally, we've kind of gone through the gamut, and I think we have a lot of information to tell people as to the pros and cons. And I think this was just excellent. So you guys, thank you very much. This is In Your Corner with CORA, 9/2/2020, in the middle of the pandemic. So hopefully we get out of the pandemic soon so we can get out and get back to the gym and lift some weights. Thank you, gentlemen.